So pain management after shoulder surgery has changed. And if you're still following the old playbook and the old rules, you may be suffering more than you need to. From a drug called Journavx to other yet to be released opioid pain medicine that's not addictive, to smarter layering of the medicine, here's what actually works in 2025. There's some key points to remember. One, pain anxiety is normal. If you're worried about pain, it's normal. Today's options are better than ever, and we will cover what pain control looks like in 2025, how to stay ahead of the pain without relying on just the short-acting opioids. So I did a video a few years ago about pain, and I will let you know what has changed and what has stayed the same. There are still things that are valid from that video to now, but there's some other things that are more relevant and are new from that last video. So if you're dealing with pain, preparing for surgery, recovering from surgery, I'll break it all down to you so you can understand it, so it makes sense. I've seen what works, and I've seen what doesn't work. And I'm here to give you the answers to make a difference in your recovery. Hey there, I'm Dr. Daniel Orcutt. I'm an orthopedic surgeon. I've helped people, over 1,000 people, recover from shoulder surgery and shoulder injury. So let's get into it. And stay tuned to the end because I'll tell you about some cutting edge stuff coming that may or may not be relevant to when you watch this video. Okay. Also, if you're ready for surgery or getting ready for surgery, click the link below and we'll give you our free pre-op checklist. So just click the link below. All right. Again, some things still hold true from the old video, and there's some new things that are, well, quite frankly, new that I didn't know about that are now current, are now available today. So the number one myth that we talk about is what people think, when is the pain going to hit? The pain hits usually a couple days after surgery. It doesn't hit right at surgery because you have a block. Now, occasionally a block doesn't work, and you might have pain immediately after surgery, but typically the block works pretty well, and people go home without any pain. And that's great, except that can be a problem because you might not take the pain medicine before the pain hits, which is often what we need to do. So then a couple days later, a couple days after surgery, the nerve block wears off. And so again, typically the first line of defense is the nerve block. So the nerve block is an injection, usually here, a supraclavicular block, where it actually blocks the nerves going to your shoulder. And that there are different medicines that people use or anesthesia use. A lot depends on where you are in the world, where are you in the country. It depends on what insurance may or may not pay. There are injections that are longer acting, there are injections that are shorter acting, there are different medicines. So they're all anesthetics, which means they all numb the nerves. They just work in a slightly different mechanism and maybe a slightly different time, right? So the nerve block eliminates the worst pain, but also delays the pain for people. So day 2 or 3, usually when the block wears off, 24, 48 hours after, and then the pain is really intense. Because what we have this thing called rebound pain, which is pain that is created from the release of those nerves once the block wears off. That rebound pain can be minimized, and we'll talk about that in just a minute. How do we minimize that rebound pain? Because that's important. Because once you get that rebound pain, patients may panic, and they're not expecting such a severe influx of pain. So again, we'll talk about how do we decrease that. But let me know down in the comments, what have you found to be the best way to control pain after surgery? And if you think it's nothing or you don't have any idea, then just say nothing. That's fine. I would just like to know kind of where we're at. But first, let's walk through kind of the base protocol of pain meds most people are doing after surgery now. So the base layer usually includes a Tylenol and an anti-inflammatory. Typically in the States, it's going to be either meloxicam or Celebrex, right? And those two medicines, depending on which medicine they choose, will be once or twice a day. And they are scheduled. The Tylenol is scheduled usually every 8 hours, and the meloxicam and the Celebrex are scheduled. So every whatever the duration is, it helps decrease the inflammation and the soreness. And so that is, again, it doesn't have anything to do with what you feel. It has all to do with getting this steady state of anti-inflammatories in your system, okay? So if your doctor is not giving you Tylenol and an anti-inflammatory, you should ask them why. There may be a good reason, but I think usually most people at this point are doing that, again, in a scheduled manner. So we can have a little bit of base of anti-inflammatory, a little base of pain relief, pain control with Tylenol. Now the step 2 is actually scheduled medicine. So usually there's 1 or 2 scheduled medicines. One is called gabapentin. Gabapentin actually is the medicine that helps blunt that rebound pain after a block. So gabapentin usually at night for a few days, or maybe giving every 12 hours for a few days. Again, that decreases that rebound sensation of pain after the block wears off. And the second thing is usually a long-acting opioid like OxyContin or MS-Contin. And oftentimes it will be on the bottle, it can say morphine. It's a long-acting morphine. And sometimes people get confused and they worry about they're getting a 20 milligram morphine or a 30 milligram morphine. They're, oh my gosh, I'm not going to take it because I'm worried what's going to happen. But this morphine is typically a long-acting morphine. It's every 12 hours. Again, it's a scheduled dose, usually for a few doses, 2, 3, 4, depending on what your doctor does. And that scheduled dose, again, is 20 milligrams, but it's spread out over 12 hours versus, medicines that, the typical short-acting, which is really only a 4-hour medicine. So that 20 milligrams is not as big or as scary as it seems. Now, sometimes the pharmacists actually don't appreciate that either, and they may tell you that you shouldn't take them both. We'll talk about the short acting in just a minute. So that short acting, we'll talk about. That long acting, again, a 12-hour, gabapentin is usually about 12 hours. The long acting morphine is about 12 hours, and that's another base. So we have a base of anti-inflammatory, we have a base of gabapentin, then we have a base of that long acting narcotic. Now, that may seem like a lot, but it helps really decrease the need for what we are trying to avoid, which is short-acting narcotics. And so then we add onto this as an add needed, what we call a PRN medicine, which would be a short-acting opioid. Again, the short-acting gives you pain relief pretty quick, but it comes down pretty quick too. And so they're not ideal for long-acting pain medicine, but it can be good. In the first few days, often we will take oxycodone or hydrocodone. Now, the key thing with oxycodone or hydrocodone, it may be just that in itself, but oftentimes it has Tylenol in it too. So if you look at your prescription bottle, it may say 5 dash or slash or something 325 or 7.5 325 or 7.5 500. So the first number is actually the narcotic piece. It's either the hydrocodone or the oxycodone piece. If you have another number after that, like 325 or 500, that's actually the Tylenol piece, this is important because you need to know what you're getting. And so some doctors will just give the pure opioid and not the Tylenol. But if your doctor gives the opioid plus the Tylenol, then you need to be aware of this. You just need to know and talk with your doctor, because if you're taking Tylenol scheduled, right, and then you have a narcotic that has Tylenol in it too, just need to be careful we're not getting too much Tylenol. So just be aware of what you're taking, because that's important to make sure we don't overdose on Tylenol. So that's, again, make sure that you talk with your doctor, make sure you look at your meds and understand what you're getting. Is it just the narcotic, or is it narcotic plus something else? So let me know down below whether you know if your narcotic is combined or by itself. So just let me know below. So now we have a new thing, new in 2025, is called Journavx. It's also spelled Suzetrigine. I have a hard time pronouncing it. So the brand name is Journavx. Journavx is the first new non-opioid pain medicine in the last 20 years. It just got FDA approved in 2025. So it blocks the specific sodium channel. Doesn't matter. It's a nerve. It's a channel within a nerve that provides pain or creates pain. So it blocks that. So it blocks the pain. The good news about this is it's not sedating, and doesn't create euphoria. So that's a great thing if you're trying to find a medicine that will control pain, but not worry about the addictive and other sedative side effects that we see typically in opioids. So there's these decreased side effects. The problem is, the catch is, it's expensive, and at this point it's not widely used because it's expensive and the insurance companies don't have it on board yet. So for now, it's promising, and it may be available to you when you see this video in the future, but right now it's not quite on the front line. Okay. There's other medicines that we may be giving: stool softeners, Benadryl, antiemetics, or anti-nausea medicines. So we know that if we take narcotics, we have increased risk of constipation. So sometimes it's good to start that stool softener before, or when you're starting the medicine, before you get constipated. Benadryl, sometimes people get itchy after taking narcotics, so Benadryl can be helpful in decreasing the itch. It's also a little sedative, so if you're having trouble sleeping, sometimes your doctor might recommend Benadryl too. And then lastly, the emetic, or the nausea medicine like Zofran, that can decrease the nausea, because after surgery, you haven't eaten in a while, you're taking narcotics, taking a bunch of medicine. So oftentimes we get a little nauseous, and so Zofran might be prescribed as well. Now these may be prescribed again with that big bundle that you get before surgery, or if you call in and say, hey, I'm having itching or nausea, they might prescribe it after surgery too. Okay, so we've talked about medicine. So what other things can still help after surgery that it's not a medicine? So just like in my previous video, there are things you can do outside of medicine. And the biggest thing is ice, right? Ice and compression still matter. To me, especially for the first 48 hours. Again, if you put ice on it, you get the compression on it, decrease the inflammation, decrease the pain. That's very helpful. I think after a couple days, then you can decide whether it's helpful for you or not. You can do it every 2-3 times a day, 20 minutes on, 20 minutes off, that kind of stuff. I think ice can be helpful, especially after surgery, after therapy. Again, decrease the inflammation, but also just decrease the discomfort. So that's important, I think, really in the first couple of days. Afterwards, maybe more important after doing a vigorous PT or doing something vigorous around the house. So if you have decreased swelling, and if you have more comfort, you have better sleep, typically it's a better or easier recovery. Also, make sure your arm is supported. Prop your elbow up on a pillow if you're not in your sling. If you are walking around, good thing to have a sling so you don't hang loose. When you're hanging that shoulder down, gravity pulls it down, more pain. So that's important to give that relief to the shoulder, a little support to the shoulder. And since we talked about sleep briefly, a quick note about sleep, right? Pain at night often lingers, even when daytime your pain is not so bad. A lot of that has to do with your distraction. So during the day, you're trying to do things, watching TV, whatever, and you're distracted from the pain. The brain is amazing. It can be distracted from the pain. Unfortunately, at night, there's nothing to distract, right? We just want to go to sleep. We just want to rest. And so oftentimes the pain seems worse at night. And there are a few different reasons, but I think a big reason is just because your brain has nothing to think about. So all I can think about pain. So if you're having pain at night, it is typical. So if you need narcotics more than a few days, especially at night after therapy, it's accepted, right? I think, yes, as physicians, we're pushing to get off short-term narcotics as soon as possible. But you also have to understand that this is a big surgery, painful surgery, and you may need narcotics for a little bit longer than you would like to be on it, or that your doctor would like to be on it, or the doctor, not the doctor on it, of course, or the doctor would like you to be on it. So in my experience, if you need pain medicine for a little bit longer, or you need to be sleeping in a supported position for a little bit longer, you're not doing something wrong. You're just recovering. And now, hopefully, you're doing it smarter because you understand the whole picture of what's going on. Okay, so we're going to talk about the cutting edge. So what we think probably is the cutting edge, we're going to begin to start doing medicines actually before surgery, not after surgery, getting the body ready, kind of prepping the body for the insult that we're going to create as surgeons, the surgery. So there's been a few people who are doing medicines before surgery, and that probably makes sense. Again, get the body ready. Also, this is not necessarily new. This is kind of new and old. We have what's called a TENS or a PNS. Those are two different ways to block the signal of the nerves to your brain. So it helps decrease pain. Now, TENS units, there's some controversy whether TENS units work or not. 10 unit creates the electrical signal, actually is through a pad or electrode on your skin. It sends it like the signal. I have seen many patients have improved pain with the TENS unit, but the data, the jury is still out so much on whether a TENS unit works or not. And then the PNS is actually to take a little electrode and actually place it, so implant it around that nerve that's going to your shoulder to decrease that. So that's perhaps in the future. We use PNS in other areas like spinal cord stimulators and that kind of stuff. So it's not being used routinely at this point, but perhaps it will be used routinely more often in the future. And lastly, this cool thing, like we talked about, you hear nanotechnology and like everything. So there's an idea of nanotechnology, which you actually inject the medicine in your shoulder, right where the problem is, and then you can somehow, some way, with an electrical device, actually create the releasing of that medicine, right? So it's maybe in a special kind of capsule, so to speak, that the medicine's inside, and then you press the button, and it releases it inside. So you can control your pain medicine, and that's directly there, so it doesn't have to go through your whole system. So that's really interesting, and that probably is the next wave of how do we control pain, not just after shoulder surgery, but any surgery. So that's it. That's my update of pain control after surgery in 2025. If you liked this video, please press the like button. Please subscribe to the button so we can give you more information, more data, more videos in the future. If you have a comment, something you would like to see or you would like me to talk about in the future, please comment that and say, and I really appreciate all the comments. I'm getting many, many comments, more so in the last few months. I really appreciate it. It helps us direct the channel. So thank you. Hope you have a great day. Hopefully you're recovering smoothly, and we'll see you next time.